Buenas tardes, bienvenidos a la gran sesión académica del grupo Neurovirus Emergentes en las Américas. Este es un proyecto financiado por el Instituto Nacional de Salud de los Estados Unidos y es una colaboración entre la Escuela de Medicina de Johns Hopkins, la Universidad del Valle y 7 instituciones académicas en Colombia. El grupo NEAS está enfocado a investigación de los problemas infecciosos que están asociados con enfermedades neurológicas. Hoy tengo el gran honor de invitar a la doctora Deanna Saylor. La doctora Deanna Saylor es una médica neuróloga graduada de la Universidad de Johns Hopkins en su escuela de medicina y también como parte del entrenamiento en neurología clínica. Ella también tiene entrenamiento en neuroinmunología y enfermedades neuroinfecciosas. Y en este momento la doctora Saylor no solamente trabaja en el Hospital Johns Hopkins, pero también está basada en la Escuela de Medicina de la Universidad de Zambia, que es la primera escuela de medicina de tener un programa de entrenamiento en neurología clínica. La doctora Saylor es una pionera en trabajar y dedicarse a los estudios de los problemas neurológicos en África y en este momento se está precisamente en la capital de Zambia, en Lukasa, y muchas gracias a la doctora Saylor por unirse esta noche. El tiempo de diferencia para ella es más de 7 horas, de tal manera que le agradecemos estar levantada para dar esta conferencia. Deanna, thank you so much for joining us, and we welcome to the Neurovirus Emerging in the Americas Network. This is the grand round that we have every month, and it's really a great pleasure and great honor to have you here, and we are very anxious to hear your experience and your expertise on HIV and infections associated with HIV and the neurological consequence of that.
Thank you so much, Dr. Pardo, and thank you for the invitation to be here today. I'm excited to share an update with you about the neurologic complications of HIV. So good evening, good afternoon to everyone. As Dr. Pardo said, I'm coming to you from Zambia, where it's just turned midnight. So I'm happy to be ringing in the new day with you. I don't have any disclosures relevant to this talk, but these are various funders from whom I've received grants in the past few years. And so today, I know that we have people from a variety of backgrounds. We have infectious disease specialists and we have neurologists. And so I'm going to start with just a basic HIV review for those of you who don't think about HIV every day. And then we're really going to talk about the 3 main neurologic complications of HIV infection, looking at cognitive impairment, neuropathy, and stroke. And for each of those, we'll talk about the epidemiology, clinical characteristics, some pathophysiology, and then some work that I've done either in Uganda or in Zambia related to these disorders. So starting just to get us all on the same page with HIV. HIV stands for human immunodeficiency virus, and this is a retrovirus that causes AIDS, which is acquired immunodeficiency syndrome. HIV infects immune cells, particularly macrophages, monocytes, and CD4 positive T cells. And the clinical syndrome for HIV consists of an acute infection, which is called acute retroviral syndrome. And this produces a flu-like illness where people may have fevers, they often have myalgias, fatigue, and just generally don't feel well. And this usually lasts for 3 to 10 days, and then it spontaneously resolves. Following this acute infection, patients have a very long asymptomatic period, even up to a decade, where they really have no HIV-specific symptoms at all. And then eventually they develop immunocompromise where they are at risk for developing opportunistic infections due to immunodeficiency. And so this is where AIDS comes in. AIDS is defined as a CD4 count of less than 200, or AIDS defining illnesses, which include opportunistic infections of the central nervous system. This is just a graph illustrating what we just talked about. So if we look first at the red line, this is the CD4 count, and a normal CD4 count is somewhere between around 600 and 1,000. And so during acute infection, the CD4 count is initially normal. And then about 1 month after infection, it has a pretty significant decline at a steep rate, but then that mostly recovers and again kind of plateaus in the normal range for years and years before it really starts a slow decline. And eventually, after somewhere between 2 and 12 years, the CD4 count is less than 200, and this is when your opportunistic infections can develop. At the same time, we have the HIV viral load, so the number of viral particles that can be detected in the plasma. And we see this very steep rise in the setting of acute infection initially, but then also a steep decline as the immune system sort of deals with the initial infection and reaches an equilibrium with mostly a normal CD4 count and a pretty low viral load. But then eventually, again, over years, if HIV is untreated, that viral load will steadily increase and then eventually exponentially increase once the immune system becomes immunocompromised. And so the two main clinical markers that we follow for HIV control are the CD4 T cell counts and the viral load. Stepping back now and thinking about the global HIV epidemic, these data are a few years old now, but in 2018, there were about 38 million people living with HIV worldwide. And there was almost 2 million new infections annually and about 750,000 global AIDS-related deaths every year. And it's important to note that the infections are not distributed equally. About 70% of all people living with HIV reside in sub-Saharan Africa. And so you can see that almost 21 million of the 38 million people reside in Central and Southern Africa. I like this map better because this shows you the proportion of the global HIV infections in each landmass. And so again, this really illustrates just how disproportionately sub-Saharan Africa is affected by HIV, but also the Indian subcontinent, Southeast Asia, China as well. And so diagnosis of HIV is generally done via a rapid antibody or antigen test. And then as we mentioned, we monitor the CD4 count and viral load. And our aim is what we call viral suppression. And that just means that the viral load, the copies per milliliter, are less than the threshold of detection for the assay used. And that's usually about 30 copies per ml. So you'll hear me talk about suppressed, virally suppressed, meaning an undetectable viral load. And we do have very effective treatment, as most of you know, where we have combination antiretroviral therapy. So these are at least 3 antiretroviral drugs that patients are taking. And when they take these daily with effective viral suppression, the lifespan of people with HIV approaches normal. And so when we think about HIV in the nervous system, I like to think about 3 categories of involvement. And the first thing to know is that in all of these categories, both the central and peripheral nervous system can be involved. And essentially every part of the neuroaxis is affected by HIV. And they're affected by one of 3 mechanisms. So the one at the bottom here are syndromes due to severe immunocompromise. So these are really opportunistic infections that are found in people with poorly controlled HIV. Thankfully, these are less common today with the widespread availability of antiretroviral therapy. And so I'm not going to talk at all about these today. I'm going to focus on the direct effects of HIV infection and then the toxicities of the antiretroviral therapy that we use to treat it. So really focusing in on these 2 mechanisms as we talk about the 3 main complications that we still see in people with HIV today. And so the first one that I want to talk about is HIV-associated neurocognitive disorder, or HAND. So hand really is a spectrum of cognitive impairment. So there are currently 3 different hand stages. There's asymptomatic neurocognitive impairment, mild neurocognitive disorder, and then HIV-associated dementia. And they increase in severity as you go down this table here. And if we think about this first stage, asymptomatic neurocognitive impairment, these are patients who are totally fine. They have no subjective complaints. They have very few objective abnormalities on a clinical exam. So this is really sort of a research definition where when we do formal neuropsychiatric batteries in these patients, we can find some abnormalities, but otherwise they're totally well. So this one is not so clinically relevant for most of us as we practice in the clinic. The ones that we tend to think more about are mild neurocognitive disorder and HIV-associated dementia. And I think of these as sort of akin to Alzheimer's disease, where we first think about mild cognitive impairment, and then eventually that can later progress to Alzheimer's dementia, although it does not always progress to Alzheimer's dementia. And this is the same way. So patients who have mild neurocognitive disorder do have some subjective symptoms of memory loss or processing difficulties, but they're still able to function, they're still able to work, they're living their normal life with just some symptoms. And then some of those patients will remain like that. Some will even revert to asymptomatic impairment. And a very few of them will actually progress to full-on HIV-associated dementia. And these are patients who have more severe cognitive impairment and then also are unable to function in their daily activities as they did before. And so, as you can imagine, the diagnosis here is based primarily on formal neuropsychological testing or neurocognitive testing, and then also an assessment of the level of functional impairment that's caused by any cognitive deficits. And it's important to note that we have to exclude other confounding factors that can lead to cognitive impairment in this population. So this includes learning disabilities, drug and alcohol abuse, depression, psychiatric comorbidities, anything else that may also be contributing to the cognitive impairment. And when we think about the epidemiology of hand, it's really a tale of 2 completely different stories. So before we had widespread effective antiretroviral therapy, 35 to 40% of people would actually develop the most severe form of hand, the HIV-associated dementia. And once someone developed HIV-associated dementia, it was essentially a marker of end-stage HIV disease. They continued to have progressive cognitive impairment until they died. There was no remission, and they often died within 6 to 9 months. And you can see from this graph here that hand affected more than 50% of patients, and it was sort of equally divided, about 20% with asymptomatic impairment, 20% with minor neurocognitive disorder, and then maybe 25 to 30% with HIV-associated dementia. But now that we have widespread antiretroviral therapy, we see a very different picture. Now, instead of 35 to 40% of people developing dementia before death, only 3 to 5% of people develop dementia. And even when they do, it often remits spontaneously. There's frequent improvement. And so we really don't have this progressive fatal form of dementia anymore. But if you look overall, hand still affects 40 to 50% of people with HIV these days. It's just that now more than half of the people who are affected actually have asymptomatic impairment. And these more severe forms are much less common, particularly HIV-associated dementia. But why do we still care about hand if not many people are very symptomatic? And the reason for that is that any hand stage actually leads to a reduced quality of life. So people report trouble with communication or finances, remembering appointments. And also it can be associated with reduced adherence to antiretroviral therapy. And reduced adherence to antiretroviral therapy leads to more poorly controlled HIV infection, and more poorly controlled HIV infection leads to worsening cognitive impairment, And then worsening cognitive impairment, again, leads to even worse adherence. And you really can get into this loop of worsening adherence leading to worsening cognitive impairment, and so on and so forth. But it's not only the epidemiology of HAND that has changed in the ART era. We also know that the clinical presentation has changed. So before we had effective treatment for HIV, HAND was a very classic subcortical dementia. So there was very prominent psychomotor slowing and apathy, a lot of frontal disinhibition and executive dysfunction. And then there were these sort of Parkinsonian signs. So there was tremor, there was bradykinesia, gait and motor impairment. So very, very classic subcortical dementia. Now in the current era, we see a more mixed picture with both cortical and subcortical phenotype or symptoms, and a milder phenotype overall, as we just discussed. And so in patients today, we see more prominent memory difficulties. We see less of the psychomotor slowing, apathy, disinhibition. We rarely see the tremor and bradykinesia or the gait impairment anymore. And this is really starting to look a lot more like an Alzheimer's disease, although there still are some subcortical features that differentiate it. So who develops HAND? And there's a lot of different risk factors. And I like to think of this as sort of the multiple hit hypothesis, like we think about for malignancies. So the more things you have working against your brain, working against your cognition, the more likely you are to develop symptomatic cognitive impairment. So we know that cognitive impairment increases with age, and that's true for people with HIV as well. We also know that the more poorly controlled HIV disease is, the more likely you are to have neurocognitive impairment. So a lower CD4 count, a higher serum viral load, and then other AIDS-related symptoms or infections like opportunistic infections. We also know that low platelets and anemia also strongly predict the presence of neurocognitive impairment. And pathophysiologically, we don't really understand why that is. And it's also interesting because the risk factors for cognitive impairment have also changed in the pre-antiretroviral therapy era compared to now in the widespread antiretroviral therapy era. And so many of the risk factors are different, but the low platelets and anemia have actually remained in both of those epochs, and we're not sure why that is. There's also an association between neurocognitive impairment and depression, and there's a lot of debate within the field about whether this is more of a pseudo-depression or a pseudo-dementia related to depression, or whether it's truly cognitive impairment associated with depression. And the overarching thought is that even when patients are taking antiretroviral therapy, it certainly helps to reduce ongoing chronic systemic inflammation caused by HIV infection, but it does not completely normalize that chronic inflammation. And so there's still this sort of mild inflammatory milieu in the brain that can lead to higher rates of depression as well as cognitive impairment. And so we do think that these sort of travel together and don't necessarily cause each other. We also know that patients who have the gene for apolipoprotein E4, which is also a risk factor for Alzheimer's dementia, are more at risk for HIV-associated neurocognitive impairment as well. So if you're seeing a patient with HIV in clinic and you want to know how to evaluate them, the first thing you can do is do a screening cognitive test with them. So something you can do right at the bedside that won't take a lot of time. And to do this, you know, in many disorders, we use the mini mental status exam or the Montreal Objective Cognitive Assessment, the MOCA. But the scale that is most specific to the cognitive domains that are impaired by HIV infection is the HIV Dementia Scale or the International HIV Dementia Scale. And the International HIV Dementia Scale is meant to be less culturally linked and less education dependent than the HIV Dementia Scale, which was developed in the US. And so in our setting here in Zambia, we use the international version. And I would imagine that that would be the version that would be most useful for all of you as well. So on this international HIV dementia scale, it should take about 5 minutes to perform. It's just a pen and paper test that you can do right at the bedside. And a score of less than 10 indicates the need for formal neurocognitive or neuropsychological testing to see if the patient meets objective criteria for HAND. In the meantime, we want to be thinking about those confounding factors that may also be leading to cognitive impairment. And then oftentimes we're going to get neuroimaging in these patients, not necessarily to confirm that this is HAND, but more so to ensure that we are not missing a mimic, like an opportunistic infection that needs more urgent treatment. And so what we tend to see on an MRI of the brain are the findings I'm showing you here. So all of these are axial MRI slices. I have a T2 on the left and then flare in the middle and on the right. And so what you can see are really these sort of confluent T2 and flare hyperintense lesions. They tend to be in the subcortical white matter, tends to be mostly symmetric. There's no mass effect, there's no diffusion restriction, and there's no enhancement with these lesions. And so once you've made the diagnosis of HAND, unfortunately, we are still sort of in the holy grail search for an actual disease modifying treatment. We really don't have anything that alters the course of HAND for most patients. And so I like to think about this again, is there some sort of modifiable risk factor that I can do something about that may be contributing to the cognitive impairment? Do they have a B12 deficiency? Do they have a thyroid abnormality? Are they still using drugs and alcohol? Can we intervene in any of those to try to optimize cognition? You certainly want to make sure that patients are on antiretroviral therapy and work closely with your infectious disease colleagues to ensure that they're on the right regimen and that their HIV disease is well controlled. And then we're really thinking about supportive therapies. So making sure that they have a caregiver who's aware that they have cognitive impairment and can provide extra support, especially around adherence to medications. If possible, getting them involved with a speech and language pathologist who can do cognitive therapy, and then really trying to stimulate them both from a mental and physical perspective. So making sure that they're exercising every day, even a 15-minute walk around their neighborhood, and having some sort of social and cognitive stimulation with peers is also important as well. So what causes HAND? What is the pathophysiology? And the truth is that it's likely multifactorial, and we don't completely understand what causes it. But we know that as I mentioned, HIV infects many different types of immune cells, but it does infect monocytes and cause them to activate. And then they are able to pass through the blood-brain barrier where they infect and activate perivascular macrophages. Lymphocytes are able to get through a leaky blood-brain barrier in the setting of kind of systemic inflammation. Eventually, we get to infected and activated microglial cells. And these cells are now factories to produce viral proteins, including GP120, TAT, and VPR. And all of these are actually neurotoxic when they're released. So even if they're not being released as full viral particles, the proteins themselves have neurotoxicities, can lead to more activated microglial cells, and then on the neurons themselves can cause synaptodendritic pruning, can cause neuronal injury, can lead to excitotoxicity. And so we really have this spiral of more and more activated immune cells within the brain and then ongoing neuronal injury as well. This is a review of some of the biomarkers that have been associated with cognitive impairment in people with HIV. And I don't think the exact biomarkers are important here, but what I do want to show you is that the biomarkers come from a variety of different pathways. So there are biomarkers of cell stress, of neuronal injury, of oxidative stress, of energy metabolism abnormalities, and immune activation and glutamate regulation. And so really this is, you can think of this as ongoing persistent chronic inflammation that really harms the brain through a multitude of pathways. There's also some other potential mechanisms. So there is something called CNS compartmentalization. So HIV is a retrovirus, and as you'll remember, retroviruses do not have proofreading mechanisms when they replicate, and so mutations occur very, very frequently. And we know that HIV enters the brain within 2 weeks of primary infection. And it's going to continue to replicate initially in the brain until antiretroviral therapy is commenced. And so it's very possible that the virus that enters the brain can subsequently undergo a mutation that makes it different from the virus that is circulating systemically. And sometimes that mutation that occurs in the virus in the brain can even be a drug resistance mutation, such that the antiretroviral therapy that the patient is taking may do a very good job of suppressing the systemic virus, but there may be resistant populations in the brain to that medication such that there's ongoing replication within the brain. And so when you have two different lineages of virus, one in the brain and one in the periphery, that's called CNS compartmentalization. And if that then leads to a situation in which the viral load is undetectable in the blood, but there's ongoing active replication within the brain, and you have a detectable viral load within the spinal fluid, then that's what we call HIV viral escape. And both of these conditions are associated with worsening cognition as well. There are also many different types of subtypes of HIV, and there's some thought that some subtypes may be more neurotoxic than others. And so you can see these subtypes tend to be geographically distinct. And so there's a hypothesis that population differences in their rates of hand may be due to these different subtypes. And then if we just kind of think back again to the fact that the clinical features of hand have changed with ART, we can come to the question of why has that pattern changed? And I think there's several reasons for that. And the first is that, the people with HIV before we had effective treatment are a very different population than people with HIV today. So on average, people with HIV today have spent far less time with severe immunocompromise. It used to be that even after we had antiretroviral therapy, we didn't start treatment until people became immune compromised. But that strategy has really changed in the past 5 years or so. And now, as soon as people are diagnosed with HIV, they're started on antiretroviral therapy, even if their CD4 count is completely normal still. And so it's very possible that people with HIV who are living today have actually never been immunocompromised and never met criteria for AIDS. And then we also know that antiretroviral therapy itself is toxic. And so there's been a lot of studies. This first study from 2011 looked at the effectiveness of antiretroviral medications at actually crossing the blood-brain barrier and entering the central nervous system. And based on this initial study, there was thought that if you actually increase the CNS penetration of the antiretroviral therapy medication, that you would have better neurocognitive functioning. And so there were several years where we were calculating CNS penetration effectiveness scales. And if somebody had hand, we would actually change them to a regimen that had a higher score. But then some conflicting evidence started coming out and actually showed that in patients who were on therapy that was more highly penetrant into the CNS, they actually had an increased risk of dementia. And this evidence has really continued to accumulate. And so a lot of the cognitive impairment today may actually be linked to the antiretroviral therapy that patients are on. And that toxicity may be to particular pathways in the brain that are different from the pathways that HIV itself affected before we had effective antiretroviral therapy. And then again, we talked about how HIV is a chronic infection that causes this chronic low-level inflammation that is reduced with antiretroviral therapy, but is not completely resolved. And so you end up with a situation where people have ongoing low-level inflammation for years and years and even decades. And over time, this leads to this phenomenon that we call accelerated aging. And so we often say that people with longstanding HIV infection, their biological age is about a decade older than their chronological age. So conditions that tend to happen in your 60s and 70s, chronic kidney disease, myocardial infarction, stroke, all of those happen about a decade earlier in people with HIV. And we also know, again, that there's this earlier onset of cardiovascular disease. And so there's a lot of questions about whether the hand that we see in today's era are really driven by a vascular dementia or vascular contributions. And then there's also thoughts about whether this accelerated aging and earlier onset of diseases of older age has just led to an earlier onset of Alzheimer's disease in people with HIV. There's been some autopsy studies that show increased brain amyloid deposition in people with HIV. And when you do lumbar punctures in these patients, you see lower A beta 42 levels, which is similar to Alzheimer's disease as well. And so maybe the hand that we're seeing now is really just early onset of Alzheimer's in people with HIV. So kind of shifting gear now, I just wanted to talk briefly about a study that I've been involved with for the past decade called the RACI Neurology Cohort Study. This was originally led by Ned Sachter and Maria Wayward, although Leah Rubin has now taken over after Ned's death. And this takes place in RACI, Uganda. So Uganda is here in East Africa, and RACI is a small village on the banks of Lake Victoria. And it's a prospective observational longitudinal cohort study, again, in RACI, which is a rural fishing village. Our study consisted of 400 people with HIV and 400 HIV uninfected adults. The people with HIV were divided into two groups, so 200 that had severe immunocompromise with a CD4 of less than 200, and then 200 that had moderate immunosuppression with a CD4 of 350 to 500. All of them had not yet begun antiretroviral therapy when they enrolled, but they were offered ART as soon as they met guidelines for starting ART. And then we had our controls that were age and sex matched, and they were primarily used to generate locally relevant normative data for our cognitive battery. So all of our participants were evaluated at baseline, and then people with HIV were evaluated again 2 years later. And we evaluated them with sociodemographic surveys, neuro and medical evaluations, the neuropsychological or cognitive test battery, a blood draw, and people with HIV could also agree to an optional LP or lumbar puncture as well. And so I just wanted to highlight a few of our major findings from there. And the first finding was around looking to see if there was a subtype effect of HIV. And that what we found here was that hand severity decreased after patients initiated antiretroviral therapy. But again, the prevalence of hand overall remained unchanged. So if you looked at the baseline study, about 44% of people had normal cognition. That didn't change substantially at follow-up, where about 49% had normal cognition. But what did really change was that 13% of people met criteria for dementia when they enrolled, And 2 years later, when they were on antiretroviral therapy, that number had decreased to 5%. So again, we saw a shift towards less severe forms. And then when we looked, Rakai is in an area where subtype D and subtype A overlap. And we saw that subtype D was associated with more significant cognitive impairment than subtype A when patients first enrolled in the study, so before they started antiretroviral therapy. The problem here is that subtype D is also associated with more severe immunosuppression. And so it was unclear whether this difference was really being driven by an increased neurotoxicity of subtype D, or whether it was being driven by increased immunocompromise in patients with subtype D infection. And then we also wanted to say, okay, we have half of our patients that meet criteria for neurocognitive impairment. Is that all the same? And really our data suggests that it's not. So this was a study led by Alyssa Vecchio, where we looked at how neurocognition changed in people with HIV from their baseline pre-ART enrollment to their follow-up 2 years later. And essentially what we found is that the improvements in cognition primarily occurred in learning and memory, in motor, and in some measures of processing speed. But actually, we saw declines in that 2-year period in attention and working memory and in semantic fluency. So the cognition was not affected equally in all domains. And again, you wonder, are these declines from toxicity of the medications itself? We found that the CD4 counts before they initiated ART, as well as efavirenz, one particular type of medication, were associated with less improvement in cognition. So the more severe your immunocompromise was, the less likely you were to improve even after starting medications for HIV. We also wanted to say, are there differences in how people change? And what we found is that there are subgroups that can be identified that have differing trajectories of change. And so this is a busy slide, but this is looking at the reliable change index. So how much change there was by cognitive test for given individuals. And what we can see here is that about 15% of our group only had really declines on their performance. So if you see these sort of black dotted lines, this top black dotted line and the bottom black dotted line, in between them suggests there's no change. But if you see a lot of scores that are below this bottom line, then that suggests that there is decline. So about 15% of patients simply declined despite starting on ART. Then there was about 10% that really had a mixed pattern. They had some tests that were improving, they had some that were worse, and then they had a variety that really weren't changing at all. About half of patients actually had no change. They basically remained stable the whole time. And then about 20% primarily improved. And so when we look at this in aggregate as a cohort, we can really miss the fact that people are having very different individual experiences with their cognition after starting antiretroviral therapy. We also found that learning, memory, and attention were more malleable to change after starting antiretroviral therapy than motor deficits were. So they seemed to respond better to ART initiation. And again, we saw group differences in CSF cytokine levels before patients started antiretroviral therapy. And so this really supports that there's a biological plausibility for these subgroups and that there may be individual differences in immune response to HIV infection, which lead to these different trajectories of cognition. We really feel that understanding this heterogeneity in cognitive trajectories may be the key in understanding neurocognitive impairment in the setting of HIV infection and also in developing effective treatments to prevent this cognitive impairment and identifying which patients are really going to benefit from treatments that may be developed. Because maybe when we're looking at a new treatment, maybe we should only be targeting these 15% that are actually declining. And if we test that treatment in a large cohort with a bunch of groups that don't stand to benefit, then we may mask the effect of a treatment that would otherwise be found to be effective if we were targeting it more precisely. And so we really feel that really honing in on these trajectories is going to be important. So that's what I wanted to spend the majority of the time on today, but I do want to just touch briefly on HIV-associated peripheral neuropathy and then later on in stroke. So peripheral neuropathy, again, is very, very common, affecting 1/3 to half of people with HIV. And this includes well-treated virally suppressed patients on antiretroviral therapy. And again, we have this neuropathy occurring as a direct effect of HIV infection or as a toxicity of the antiretroviral therapy. So we know that HIV has been shown to directly infect the dorsal root ganglia, Schwann cells, and oligodendrocytes. And again, you can see here that you have an HIV viral protein that actually binds to receptors on Schwann cells. This leads to increased production of TNF alpha, which then leads to neuronal damage of the dorsal root ganglia. You can also get Rantes secretion from T cells as a response to the GP120 binding to these receptors, which again can lead to neuronal damage, especially of the dorsal root ganglia. But we also know that many antiretroviral drugs, but especially the nucleotide reverse transcriptase inhibitors, cause toxicity to the mitochondria as well. And you can get mitochondrial damage that leads to peripheral neuropathy. So we have two very different mechanisms, one from HIV itself and one from the toxicity of medication. But the reality is that it's really impossible to say for sure whether someone is having neuropathy due to HIV or due to their medications based on your clinical assessment or even on electrophysiology, meaning electromyography and nerve conduction studies. We know that ARV-associated neuropathy is sometimes more painful. It can be more abrupt. It can progress more rapidly, but none of that is true all the time. And the reality is that this is a little bit of an academic discussion because the treatment for these two conditions are really the same. So how are these patients going to present? They present as a typical distal sensory polyneuropathy. So they have slowly progressive sensory symptoms that are length dependent, meaning they start distally in the hands and feet or in a glove and stocking distribution, and they ascend proximally over months or usually more commonly over years. Positive sensory symptoms are more common, meaning aching, painful numbness, and burning. And this usually is most severe at night or after walking prolonged distances, and usually occurs first on the soles of the feet. Weakness is generally not a predominant symptom, and motor involvement is usually only seen very late. So if you're seeing that early on, we should think about other etiologies. And again, the hands are rarely involved, and usually after only many, many years of untreated neuropathy. On exam, we tend to see a distal loss of pinprick temperature, light touch, and vibration, reduced or absent ankle reflexes, and again, weakness is rare. So this is a pretty typical exam for any small fiber and distal sensory neuropathy. For diagnosis, this is really a clinical diagnosis. You don't need to do additional tests to confirm the diagnosis. You can think about doing neurophysiology, like nerve conduction studies, if there's something atypical, but you certainly don't have to. And many times, because this is a small fiber neuropathy, the nerve conduction studies will even be normal. You can do a skin biopsy to determine the epidermal nerve fiber layer density. And that can be used to confirm the presence of a small fiber neuropathy. And in a research setting, we sometimes use quantitative sensory testing, but that's not really used clinically. Risk factors for peripheral neuropathy, again, are going to be similar: older age, more poorly controlled HIV infection, and then anything else that can cause neuropathy. So alcohol, neurotoxic drugs, nutritional deficiencies, or other conditions like diabetes and chronic kidney disease. I thought this was a nice chart from a 2017 review of other potential contributors to sensory neuropathy. So thinking about metabolic and nutritional causes, toxic causes, which we've mentioned, as well as substance abuse as well. And this also includes a list of tests that you can consider in investigating the cause of sensory symptoms in people with HIV. So how do we treat HIV-associated peripheral neuropathy? First, you want to remove any agents that might be causing this. So this might mean switching them to an antiretroviral regimen that is less neurotoxic. If someone is on isoniazid for TB or TB prevention, adding pyridoxine, avoiding other neurotoxic medications like metronidazole. If there are modifiable risk factors for neuropathy, we want to modify those as well. So controlling diabetes, managing chronic kidney disease and uremia, treating hepatitis C, avoiding alcohol, making sure we're optimizing nutritional status as well. Again, dietary modification. So we think about these things in our setting where many patients have a very limited diet. Should they just be on a B complex, assuming there may be a nutritional deficiency? Cassava also interferes with metabolism of B12. And so people that have a very cassava-rich diet are at risk of developing a neuropathy from that as well. And then once you've sort of modified what's modifiable, you're left with treating the pain. And so you're going to use neuropathic pain agents like tricyclic antidepressants, anticonvulsants, or topical agents, with the last step really being narcotics. The truth is that every medication I've listed here has actually been tested in randomized controlled trials for HIV-associated neuropathy. And capsaicin is actually the only one that had shown an actual benefit. That being said, you certainly want to offer patients that are having really severe nerve pain some sort of treatment. And so we do still use these. And anecdotally, I have a lot of success with these, but just to know that the evidence base for using these as treatments for HIV-associated neuropathy are not great. And then I just briefly wanted to highlight this article, which came out from the Rakai neurology cohort study that I already told you about, where we looked at the prevalence of peripheral neuropathy and what impact it had on patients. And so the first thing we found was that HIV was in fact associated with neuropathy. And so in people with HIV, almost 20% met criteria for neuropathy, compared to 7% of HIV uninfected participants. But even this was quite high for a general population, and so deserves probably more thinking about what was causing that neuropathy in those patients. We found that people who were older, women, and people with HIV were more at risk of developing neuropathy. And importantly, neuropathy was associated with poor functional status. And so it did have impacts on patients' ability to function, to carry out routine activities, as well as their quality of life. So it is something that's important to think about and make sure we're adequately diagnosing and treating. And then finally, just briefly moving on to HIV-associated stroke, it's important to know that HIV increases the risk of ischemic stroke at least 2 times, and some estimates say as high as 5 times compared to adults without HIV. And it increases the risk of hemorrhagic stroke 1.5 to 2 times. And this is especially true among women and in younger populations. And in sub-Saharan Africa, where we know the majority of people with HIV reside, HIV is a significant risk factor for stroke. And so a study in Malawi showed that HIV accounted for almost half of the population attributable risk of stroke among younger adults, so those less than 55. And it still contributed 8% among adults older than 55 as well. And so how does HIV cause stroke? There's really a variety of ways. Most of what we know is how it causes ischemic stroke. And the one that we'll talk a bit more about is that it does seem to cause a vasculopathy itself. So direct result of HIV infection affecting the endothelium of blood vessels themselves. And then this HIV-associated vasculopathy can lead to formation of aneurysms, vasculitis, accelerated atherosclerosis, and a small vessel vasculopathy as well. Opportunistic infections can also be associated with stroke, so infectious causes of stroke. There's cardioembolic phenomenon, and so certainly again associated with infections like bacterial endocarditis, but you also have HIV-associated cardiac dysfunction, which increases the risk of cardioembolism as well. We know coagulopathies are more common in people with HIV, and there's also HIV-associated hyperviscosity, which increases ischemic stroke risk. And then as far as mechanisms for increased risk of hemorrhagic stroke, again, we think about vasculopathy, but also thrombocytopenia and mycotic aneurysms in the setting of bacterial endocarditis. And so this is a diagram from Laura Benjamin's review of how we get HIV-associated vasculopathy and how that leads to stroke. And so again, what we're seeing is that you have HIV viral particles that are coming into contact with the endothelium and then resulting in damage to the endothelium. And then you get leaky endothelium, you have infected lymphocytes traversing across the endothelium, as well as an inflammatory reaction. Then we're going to start getting fibrin and thrombus forming from this damage, continued cytokine production with generation of reactive oxygen species, more leakiness and more viral particles entering the blood vessel wall itself, and eventually leading to occlusion of the blood vessel and ischemic stroke. So how does the clinical presentation of HIV-associated stroke differ? Focusing again on ischemic strokes, when we compare people with HIV and stroke to HIV uninfected populations with stroke, people with HIV are more likely to have lacunar strokes or small strokes. They're less likely to have large vessel occlusions, and actually their outcomes are usually better. This is a study that I worked on with Aparna Nutaki, who's now starting her neurology residency at Johns Hopkins, as well as Stanley Zimba, who's one of the first graduates of our neurology program in Zambia, looking at HIV-associated stroke in our inpatient setting. And what we found was that HIV infection was present in 17% of all patients with stroke, and the HIV prevalence in Zambia is only 11%. So this was almost double the rate that we would expect. And we also found that people with HIV on average were 48 as compared to people without HIV who had stroke, that the average age was 62. So they were significantly younger. And when we looked at kind of traditional stroke risk factors in the population with HIV and those without HIV, we found that those with HIV were less likely to have typical stroke risk factors. So almost 40% of people with HIV lacked any other classic stroke risk factors, only HIV itself. And then finally, this is a graph that compares the general stroke population in sub-Saharan Africa in blue to the HIV-infected stroke population in red, and then the same comparing the stroke populations in the US in red and green. And again, what I want you to see here is that the HIV-infected stroke populations had much lower rates of most of the stroke risk factors that were looked at compared to the general stroke population. And so just kind of concluding and summarizing, if we think about hand remains a common complication of HIV even in the ART era, although it's less severe. Now presents as a mixed cortical and subcortical cognitive impairment with lots of different mechanisms contributing to its development. Peripheral neuropathy also common with lots to learn about pathophysiology. And then I think with stroke, just recognizing that stroke burden is increasing in people with HIV, Most HIV-associated stroke is not infection-related anymore. And because we don't completely understand the mechanisms for HIV-associated stroke, we also don't know the optimal methods for primary prevention, secondary prevention, and even acute treatment of stroke. So lots of people to acknowledge, but in particular, I wanted to acknowledge Kevin Robertson and Ned Sachter, who were my mentors and both died recently, way too young from cancer. And then this is a picture of where I stayed in Rakai, Uganda when I was working there. And thank you for your attention. I'm happy to take any questions.
Deanna, that was fantastic. Thank you very much. And that was one of the most comprehensive reviews on HIV and neurological complications that I have heard in the past several years. And it's great that you were able to compile this in the 45, 50 minutes. I will allow my colleagues, Dr. Barreras and Reyes, to take the lead in questions and answers. And thank you on behalf of the Colombian and Latin American group of researchers and clinicians for your help. And again, congratulations for your great effort in Africa in what you are doing there. So
we have a first question in the chat already. It's actually written in English. So it's, what do you suggest for the diagnosis of acute retroviral syndrome, with the caveat that many hospitals in Colombia don't have easy access for HIV viral load tests?
That's a great question. I mean, the only way to diagnose it definitively is by an HIV viral load test. So sometimes antibody tests will be positive, and sometimes antigen tests, the rapid antigen tests, will also be positive during acute retroviral syndrome. So it's still worth testing for using the rapid tests that are available. If you don't have access to the viral load test, then I think the most important thing is to counsel the patient that they need to return for a repeat test in about 1 to 2 months to definitively find out if their acute flu-like illness may have been a seroconversion syndrome.
Let me translate that. Thank you. Voy a traducir la respuesta. La pregunta que estaba en el chat es ¿cuál es el test sugerido para diagnosticar el síndrome retroviral agudo? Teniendo en cuenta las limitaciones en Colombia para el acceso a los test de carga viral rápidos. Entonces, la doctora Saylor dijo que pues, la manera definitiva de hacer el diagnóstico sí es con la carga viral. Entonces, que si no está disponible, a veces en el estado agudo los anticuerpos o las pruebas de antígenos rápidas pueden estar positivas, entonces vale la pena enviarlas. Pero si son negativas, pues no descarta el diagnóstico, y lo más importante es decirle al paciente que vuelva en 1 o 2 meses para repetir el testing.
And I will go ahead with another question. Thank you, Deanna. It was an amazing talk. So I guess that you make many great points, but I think one of the ones that is also very critical for me is the amount of, or the severity of, immunosuppression that you're describing in some of these patients, and taking into account the CD4 counts in some of them. Because I think that sometimes we anchor in the fact that they have a diagnosis of HIV. So for instance, in the case of a stroke, how much into account you're taking the CD4 counts to do like further testing? Let's say that is not necessarily below 200, but above 500, borderline 500.
And it's a great question. What we're learning with stroke is that you don't need to invoke a second infection. HIV itself is really driving the majority of strokes at this time. And so if someone has well-controlled HIV disease, when they come in with their stroke, I don't think you need to go searching for an opportunistic infection. You know, stroke is, or HIV is their risk factor. And it's really about finding out it's hard because we don't have great treatments for HIV-associated vasculopathy, right? And so you're still looking to see, do they also have hyperlipidemia? We know many of the antiretroviral therapies cause a metabolic syndrome. So are there still traditional stroke risk factors that need to be modified? And then otherwise, it's still kind of aspirin and statin at this point until we get a better understanding of how to treat HIV-associated vasculopathy. But if a patient has well-controlled disease and if there were no systemic symptoms prior to the onset of their stroke, you don't necessarily need to go looking for a secondary infection.
Thank you. I'll do my best to be short in the translation. Thank you so much. Entonces mi pregunta era con respecto a que usualmente hacemos un poco de perseverancia con el hecho de que el paciente tiene un diagnóstico de VIH y que se nos presenta por lo menos en el escenario de una ACV. ¿Qué tanta atención le ponemos a la inmunosupresión dependiendo de los niveles de CD4? Y lo que nos responde la doctora Deanna es que usualmente el VIH por sí solo como virus es factor suficiente para causar ACV. Entonces, si el paciente no tiene síntomas sistémicos, probablemente no debemos estar buscando otro microorganismo que esté necesariamente generando el ACV. De todas formas, en este momento no hay disponibilidad de medicamentos efectivos para tratar la vasculopatía por VIH, entonces el control de los otros factores de riesgo que también están asociados a esos tratamientos, como la presencia de hiperlipidemia, también pueden estar aportando al desarrollo del ACV, y por ahora se utiliza también prevención secundaria con aspirina y con estatinas.
And I have another question coming from Dr. Pardo, actually. So in Colombia, we have a lot of opportunistic infections. So can you expand about the frequency and factors associated to opportunistic infections?
So opportunistic infections really are occurring in people who are newly diagnosed and not yet on antiretroviral therapy. With advanced disease, people who have defaulted from antiretroviral therapy, or people who have been on antiretroviral therapy for many years and have developed resistance that may have been undetected. And so despite the fact that they're complying, they still have a high viral load and low CD4 count. I think the important point with identifying opportunistic infections is that because they are occurring in people with such advanced immunocompromise, they often lack the typical findings associated with brain infections. So they may not have fevers, they may not have meningismus. It may be very subtle findings, maybe just very subtle confusion or a mild headache or very subtle focal findings. And so you really want to take any neurologic abnormality very seriously in patients with opportunistic infections, and also realize that 30 to 40% of people with opportunistic infections have multiple infections and multiple brain infections. And so you really want to do a very comprehensive evaluation, even if you've identified one, to make sure that there's not another concurrent infection that also needs to be identified and treated.
Thank you, Diana. So, mi pregunta era que en Colombia tenemos muchas infecciones oportunistas, entonces que si ella podía comentar en la frecuencia de infecciones oportunistas y los factores de riesgo asociados a eso. Entonces, la respuesta que nos dio es que las infecciones oportunistas hoy en día están ocurriendo más que todo en los pacientes que están diagnosticados de nuevo y que aún no están en terapia antirretroviral, o aquellos que estuvieron en terapia antirretroviral y pararon la terapia por alguna razón, o aquellos que han estado tomándose su terapia pero han desarrollado resistencia a la terapia, el virus digamos ha mutado y tienen carga viral alta y CD4 bajitos que de pronto fue no chequeado y no ha sido detectado. La doctora dijo que es importante recordar que los pacientes que tienen enfermedad oportunista con VIH esos pacientes suelen no tener los signos clásicos o típicos de esas infecciones, como por ejemplo no suelen tener fiebre o meningismo. Entonces que hay que tener una alta sospecha clínica de que los pacientes con inclusive síntomas relativamente menores podrían tener una infección oportunista, y también recordar que 30-40% de los pacientes con infecciones oportunistas tienen más de una infección a la vez, incluyendo más de una infección en el sistema nervioso a la vez. Entonces recordar hacer una evaluación amplia para no perder la oportunidad de tratar una infección en esos pacientes.
And I will go ahead and read the third question. So John Castro asked if, is it possible that depression can be a prodromic symptom of hand?
So it certainly can develop around the same time that hand does, just because we think the pathophysiologic mechanisms are very similar. And so I think it's important in anyone presenting with cognitive symptoms to do a careful evaluation for depression, because you're going to want to treat the depression if it is also present, especially given that we don't really have effective treatments for hand. If it is depression related, treating the depression may actually result in improvement. So I think it is possible, and in anyone presenting with cognitive symptoms, making sure you're screening for depression and mood disorders is important.
Entonces, eso sigue siendo un área de controversia. Realmente es cada paciente que esté debutando con síntomas cognitivos, siempre asegurarnos de que se estén haciendo los screenings de depresión y alteración del estado de ánimo, porque pueden también coexistir y muchas veces tampoco se están diagnosticando a tiempo. Creo que voy a ser corta con esa respuesta. Dr. Saylor, I think that you have been very generous with your time, and especially because it's more than past 1 a.m. in Zambia. So thank you again. I know that Dr. Parra has written an extra question. I don't know if we have just a few minutes to answer that final question for her. She's asking when is the right time to initiate the RT after CNS, considering potential iris development.
That's a great question. And again, there's no straightforward answer because it depends on the CNSOI. So we know that for cryptococcal meningitis, there is benefit in waiting about 6 weeks after initiating treatment for cryptococcus before initiating ART. On the other hand, with TB meningitis, we know that there's a survival benefit for initiating ART as soon as possible after initiating TB treatment. And so you don't want to delay in the case of TB meningitis. And then with the other ones, with toxoplasmosis and PML, there's really no clear data. And so generally we start ART within 2 to 3 weeks. So you're really only delaying for cryptococcal meningitis, but you are carefully monitoring for iris and treating as needed if it develops.
Mm-hmm. Entonces, la respuesta a la pregunta que hacía la doctora Parra es con respecto al inicio de la terapia antirretroviral posteriores a infecciones oportunistas en el sistema nervioso central. Y la doctora Saylor nos comparte que depende realmente del tipo de infección. Usualmente casi que la única neuroinfección en la cual se espera es infecciones asociadas a criptococo, y esto por el riesgo de desarrollo de iris. Entonces, en eso serían 6 semanas. Varía con otros gérmenes. En el caso de tuberculosis, realmente se recomienda el inicio tan pronto sea posible, y datos con toxo o PML no son tan claros. Entonces, realmente con la única que se retrasa el inicio es con la presencia de criptococosis. Okay, Deanna, I think that's it. So Dr. Saylor, again, thank you again for joining us. It's been a pleasure having you.